نبدأ guys. How much do we have? 36?
Yeah.
Okay, perfect.
Yeah.
Okay. Great. Okay, so good morning, everyone, or good afternoon, and welcome to our weekly seminar series. And today we are happy to host Dr. Belhocine. Dr. Belhocine is a PhD in bioinformatics and genomics. He holds a master's degree in microbiology from the University of Blida, Algeria, bachelor's degree in cell and molecular biology, and a master's in bioinformatics, genomics, and structural biochemistry from Lumini University in France. His research focuses on the application of large-scale genomic approaches to understand epigenetic mechanisms associated with the development of normal and leukemic lymphoid cells. Throughout his experience in laboratories at the Center of Immunology Marseille Lumini and the Technological Advances for Genomics and Clinics Laboratory, TAGC, Dr. Belhocine has acquired extensive knowledge in experimental and computational biology. In a more specific way, he is an expert in transcriptomic analysis and chromatin immunoprecipitation coupled with deep sequencing and RNA sequencing analysis. Dr. Belhocine is proficient in coding, including R, Python, and Java. He is currently a senior bioinformatician at the MBG lab in Dubai, and where he supervises a clinical NGS analysis. In addition to that, Dr. Belhocine develops and oversees research training programs in collaboration with many Algerian universities. So Dr. Belhocine, it's a great pleasure to introduce you and manage your talk today and have you as our guest speaker for today's seminar. We are very happy and very excited to hear about your research about CAR T cells, and the floor is yours.
Assalamu alaikum. Bismillahirrahmanirrahim. Thank you, Dr. Malika, for the introduction. So as Dr. Malika said today, I will present this new therapy called CAR T, and I will give you the basics and some promises and some variation in this therapy. So starting by how this idea came. So first, we know all this traditional medicine that anyone who's sick, he go to the doctor, diagnostic the disease, give you the same treatment like any other patient. And the problem was that some patients will benefit from this treatment. Some others, they don't have any effect. And even worse, some patient will have side effects, very like heart side effect. So the idea comes for the personalized medicine, where each patient receive a right medicine tailored for his exactly his disease. So with the discovery of DNA and the coming of genomic sequencing, we start looking for the biomarker of diagnostic and trying to identify some key factors in each disease to tailor and to identify some treatment specific to this disease. So each patient will receive different treatment, not like before, the same treatment for all. And like this, everyone will benefit from individualized treatment. So in case of the leukemia and the cancer blood, you can see that we witness this 60 years, past 60 years, very rapid development and change of the paradigm. So 60 years ago, we call it just disease of blood. And 10 years later, we start understanding that there is two kinds of disease of blood. There is leukemia and lymphoma, for example. And later, 10 years later we start like defining some cluster like chronic leukemia, acute leukemia, or pre-leukemia, and on. So, but today with the coming of this genomic and diagnostic tools, we start like identifying really specific and unique type of leukemia. And we have now more than 40 unique type of leukemia identified, and around 50 unique lymphoma type identified. And this, with this new shift and the new paradigm, we ameliorate the survival of the patients 70% more. And we start like making some individualized medicine. In the market now, there is around 250 medicine that are developed only for this kind of leukemia or lymphoma. So if we are talking about leukemia and lymphoma, it's a blood disease. We need to understand why the body, the human body, cannot identify by himself these cancers and eliminate them. So before that, we need to understand the normal process. So our immunity have two kinds of immunity: cellular immunity and humoral immunity. So the cellular immunity based in the presentation of the cancer cell or the microbes of the cancer cell by MHC1 antigen, presenting the antigen for the cytotoxic T cells. And this recognition of this ligand will activate this cytotoxic T cell that will produce perforin, for example, or granulocyte that will make the cancer cell like destroy the membrane and make her leave. And there is also the humoral immunity that based in general by B cells that will recognize some antigen and activate these B cells to become plasma cells. And this plasma cell will produce, proliferate and produce specific antibodies against these cancer cells and kill these cancer cells. So, and also in our immunity, we have like different coordination between the, let me remove this, I don't know, wait here, okay. So we have like coordination between the cellular and humoral immunity to kill in general the strange body or the cancer cell. And we have like in general 3 different cooperation that we call antibody-dependent cellular cytotoxicity, where there is interaction of NK cells. And we have also antibody-dependent cellular phagocytosis, where we have the macrophage we recognize the cancer cell and phagocyte this cancer cell and present the antigen to T cells to activate the cell immunity. And also we have the complement-dependent cytotoxicity, where the antibodies, when they recognize this cancer cell, will recruit the complement, and this complement will form, will make a membrane attack to release the cell. Okay, so, and this 3 mechanisms will lead to the destruction of the cancer cell. But sometimes these cancer cells that when arrive, they have a way how to escape the immunity. So we have in general I will see here only 2 types of this escape mechanism. The first one is there is a defect in the mechanism of production of MSHC1, and the defect will make this cancer cell invisible for our immune system. And also we have the other escape mechanism by that the cancer cell or the microenvironment will produce some separation, some molecule, some interferon to suppress the tumor attack, immune attack to this cell. So it's why we have like necessity to create a new way how to treat cancer, and by immunotherapy. And the first one, it's to create like immune checkpoint inhibitors, antibodies, for example, the anti-PD-L1 and anti-CTLA4 that will block the suppressor, the immune suppressor. So they will block this immunosuppressor and allow the immunity to attack the cancer cell. And the other way that we start to look, it's the CAR T cell therapy. And I will explain today this new therapy, CAR T, called CAR T. So here I will explain the first one, that if we have a T cell and a cancer cell, and you can see that this PD-L1, it's a system that will make the cancer cell like invisible. There is this one that will make the tumor cell like invisible. When the T cell come to recognize this one, and this ligand will, this receptor will make her invisible, and it will stop the action. Stop the action of destruction. And also the T cell also present this receptor CTLA4 that will like mimic also and block the activation of the destruction of the cell. So in this first way of immunotherapy, we are blocking by antibody of this PD1 and the CTLA4. So by attacking these two receptors, we block this this invisibility, cap of invisibility, and we allow the immune system to identify the cancer and the tumor and attack them. Now I pass to to talk about the CAR T cell development. So the CAR T cell, what is it in reality? It's a T cell that we will engineer, like we will equip this T cell by like a weapon. This weapon, it's reality, it's engineered in the lab. It's two-part, it's formed from two parts. The first part, it's a specific binding domain from the tumor specific antibody. So we need to find in our disease, this tumor, what is the specific antigen that we can use, and we take it. So this target specific, and we couple it with the CD3, or we can say signaling domain CD3 of activation. So when we join these two, and we using the retro or lentiviral transduction, or even we can use the Cas9, what's the name? CRISPR-Cas9 to introduce it to the T cell and produce it in the T cell. Okay, so this is the CAR T. This cell, it's called CAR T. It's a T cell with this weapon we call the chimeric antigen receptor that created in the lab that we introduced to this cell. Okay, so what will do this CAR T cell? So this CAR T cell now have the ability with this chimeric receptor that we add to identify the cancer cell. So when it identify the cancer cell, a cascade of activation start, and this cascade have two parts. The first one, it will create like release perforin or granism and activate death receptor pathway like FAS ligand. So these two will activate an attack in the cancer cell. And also there is another way also to attack the cancer cell. It's by activating the interferon gamma or the TNF alpha, the tumor necrosis factor alpha. And these two interferon will activate the NK cell, that they will come also and attack our cancer cell and create and use the apoptosis and the necrosis of our cancer cell. So this is the mechanism of attack of CAR T cell. So when I talk about how to form it, in the beginning, the first generation, we put they use the CD3 as a signaling domain, but later to make it more like active and more effective, they start adding more and more domain to this intracellular part. So we have like 4 generations. Now we are in the next generations, and you can see that in the second generation we add what you call domain CD28 and 41BB that will make the T cell more effective and proliferate better. And later we add like more domain to make it like more effective in activating the T cells. So how to create now these CAR T cells? So the first step is to collect the T cells from the patient. So the patient will go to the hospitals and they will give a blood where we will take the T cells. After these T cells will be, we will engineer like this chimeric antigen, and we will introduce it to the T cells. We will cryopreserve these T cells and in the lab till it's the time to give it to the patients. So I will go maybe next step, you will understand better. So how to collect the T cells? So using the system called leukapheresis, this machine, it's like a machine that it will suck the blood outside, like separate the T cells from the rest element of the blood, and inject the blood again to the patient and keep the T cells in the outside. So this machines should be, it will work for 6 hours. So the patient need to stay in the hospital for 6 hours to extract these T cells. Later, in the lab, we engineers, with the help of bioinformaticians, we identify what is the target that we need to use for this cancer, and we create this chimeric antigen, and we introduce it via retrovirus or antivirus or CRISPR, like I said before, to these T cells. And after, we need to expand these T cells, like multiply these T cells, big numbers, to have enough to use it as a treatment. So after, to use it like in different months, we need to cryopreserve in different boxes to use later. Okay, after the patient may waiting before to receive this CAR T cells, maybe he will receive chemotherapy or other treatment, and this treatment is to create like how you call it, um, place to receive new T cells. Because imagine in your body you have already T cells and other immune system cells, and you add like these T cells, it will create a high number of cells, T cells in your blood. So it's better to do a chemotherapy, reduce the T cells from your body, and after they inject the new T cells. So after the transfusion of these T cells will be like a normal blood transfusion in a central line of your blood, like system, circulation system, and they will introduce it. So the patient will receive also some medications, because like every treatment they have side effects. So to avoid this side effect, the patient in parallel, he will receive some medication to control this side effect. So the patient after between 2-3 months need to be under observation and follow up to check if there is any problem. So like I said, like every treatment, they have a side effect. This treatment CAR-T have some side effects like tumor release syndrome, cytokine release syndrome, and neurotoxic syndrome. And also there is a problem of on target of or off tumor toxicity. On target, it means that maybe the introduction of this chimeric will go to different place, not that the place desired, and also maybe this antigen that we are targeting in the cancer exists in other normal cell. So imagine when we attack, the T cell will enter and attack the cancer, it will also attack the normal cell having these antigens. So we need to really choose carefully our antigen to use. Okay, here I just summarize again the different side effects. I will just go through them rapidly. So the first, it's cytokine release syndrome. So after that, the CAR-T cell attack the cancer, it will release a high number of cytotoxins and cytokines. And this high number of concentration of cytokines create like some like some problems in our body, go to tachycardia or some problems and even death. So it's very serious side effect. Also, there is the neurotoxicity. Some of this interferon, and they will pass the barrier of the cerebral cerebium, and will make like some effects, not desired effect, like aphasia or delirium or even seizures. And also the release of destruction of cancer, the cell of cancer will release all this element inside this cancer cell. So that it will create like a problem for the hepatoneurotoxicity or even cardiac arrhythmia. So you have a lot of cancer cell will be exposed, and all this component inside will be released in the blood, and they will go to be filtered in the liver. So it can create some toxicity. And as I said, the off target. So this antigen that we are using to attack the cancer that we choose maybe exist in other cells, normal cells, and we will attack them also. So, okay, so I was talking about CAR-T, but in reality we can use also other cells, not only the T cells, to create our chimeric cell. So we can use also the NK cell, and we call in this case CAR-NK cell killing, or we can use also the macrophage. So we can introduce this chimeric antigen to the macrophage. So we can create different kind of chimeric cell, and each one can can attack the cancer cell, but with different pathway or mechanism. We talked about before about the T cells that will attack through two mechanisms, by activating the NK or by leasing the cell by producing the what's the name? The granulosine or the perforin. So if in the case of NCA, it also generates the perforin and granulosine, and in this case, it will activate the T cells also to attack through the other mechanism, the cancer cell. And also, if we use the macrophage, that we will target very easily the cancer cell by macrophage. And in this case, the macrophage will engulf the cancer cell and destroy it and present this the antigens to other T cells to attack these cancer cells. So in general, to use CAR T cell therapy, we associate it with another therapy, kind of therapy. So we don't use it alone. So in general, we use chemotherapy or oncolytic viruses or radiotherapy. So in this case, that we will help like this system of CAR T to kill the cancer and to make it more effective. And also we can use a combination between this CAR cell. For example, we can use the CAR macrophage with ANCA, or macrophage with CAR T, or CAR T with ANCA. In this case, we will make this CAR, the chimeric attack, more effective by attacking the cancer cell from different with different strategy. So we will produce a better result and prognostic. So here one example of patients that have refractory diffuse large B cells. You can see here by a PET scan. So this is before the treatment. After treatment, introducing CAR T cells. These CAR T cells, we use the antigen CD19. So the chimeric, it's specific for CD19s. So this CAR T will go and search for CD19s antigen and attack the cell presenting CD19s. So they give around 2 million CAR T cell per kg. So if the patient weight is 60, so multiply 60 by 2 by million. So, and this after 4 weeks only, we can see that the tumor reduced drastically and very significantly in only 4 weeks. Now we were talking about this antigen to attack the cancer cell, but we need to choose it very well. For example, if you are in, you have a cancer B cell tumor, so which antigen we need to use? So we need to look in this cancer which antigen is specific, or at least the off-target are limited. So for example, in the B cells, we can use CD19. So the CD19, it's one of the antigen present in the majority of the tumors. We can use also CD20 as a target, CD22 also as target in case of the B cells. So in case of T cells tumor, we can target CD5. You can see that CD5, it's more specific for T cells, and CD7. And finally, if we have a multiple myeloma, we can use the CD138 or the BCMA, that will be a better target for this kind of cancer. Okay. So it's here. I want to put to explain that it's very important to choose which target you need for your cancer to use. Like this, you limit the number of off-target and the side effects in the patient. Actually, in 2013, there is around 1,200 clinical trial about CAR-T or NK. I put CAR-T, but CAR in general, 1,200 clinical trial. The majority, like 75%, are clinical against hematological malignancy, and the rest are solid tumor. If we look just the hematological part, the majority are lymphoma or multimyeloid. So there is like around 1,000 are only for hematological malignancy. Also, if we look deeper, we see that the majority of this clinical trial are using CD19. As I said, CD19, it's the more common in all the tumors. It's exposed in all the tumors. So actually, there is only six therapeutic approved by FDA, and you can see that the majority of them CD19, and the first one was approved in 2017. We can see that only this one can be used for children and young people. All the other ones are just for the adults. And for the response, this one are the, for example, ORR, it means that the object, CR, it's the effective complete relapse, and ORR, it's objective response rate. So you can see that we have some good response to this therapy, CAR-T therapy, but the problem stay that we have high level of toxicity. So many of the patients, you see 49, 46, have like cytokine release syndrome or immune cell associated neurotoxicity. There is a lot of side effects. So we need really to continue to try to find a better strategy and ameliorate the strategy.
Please mute yourself. Sorry, Dr. Belhocine. Please, whoever has his mic open, please mute it. Thank you.
So it's only 2 slides left, so I reach the conclusion. So the advantage of CAR-T cells, it's a powerful system. It attacks systematically and deeply our the cancer cells, offer a durable and protective result. It's used independently to the system HLA, so independent manner. So you don't need to introduce the system of recognition of the self. Target different type of antigen. We can, I showed you CD19, but you can in the future choose any antigen and use it like a target, and generate impressive results in the patients that they got this this therapy. Disadvantage of this therapy, you have the side effects that it's very severe sometimes. It can even lead to the death, especially with the cytokine release syndrome and neurotoxicity syndrome. And also we have the problem of off-target antigen. And also with the time, the cancer cell can develop another escape by removing this target antigen that we are using it. So for example, by chance, if one cell of this cancer don't present this antigen, so she will continue to proliferate and take the place of the other cell that die and become the dominant and offer like escape mechanism for this therapy. And the major disadvantage is the price of this therapy. You see the cost, it's like $500,000 for this, for example, the Novartis treatment. Anyway, it's a very this therapy proves that it's very effective therapy. It can be a future of our fight against the cancer or tumors, and we need really to continue to make it more democratized, to reduce the price and to reduce the side effect. Finally, I want to thank Dr. Said Dermim that helped me and introduced me to this therapy, CAR-T, and he provide me all the needed material to enter in this new field. And thank you very, very much to Dr. Said Dermim. And thank you for your attention.
Thank you so much, Dr. Belhocine. It was really an exciting talk. I learned a lot actually today. Okay, so I'll start by asking the first question. So, Dr. Belhocine, what's your takeaway about the issues leading to CAR-T failure due to lack of T expansion? So, in some cases, CAR-T don't expand, leading to the failure of the therapy. So what's kind of your takeaway on that?
Yes, there is one slide I skipped it, the reality, not skipped it, I didn't explain everything. Let me return to it. Talking about the different generation, this one, different generation of CAR-T. So this new generation, in reality, it's to add more parts that they will lead to a better proliferation and activation of the cell to proliferate more effectively and stay a longer time alive in the body. So true, it's very big problem that this cell will not stay in the body for a long time, but they are trying to generate a new generation of this chimeric antigen where they will introduce more and better survivor and proliferation mechanism.
Okay, perfect. So I wanted to ask a question about, with the boom in AI now, I wanted to kind of discuss more a comment about the use of AI and how to select the best antigen. And actually, there was a question in the chat about how can molecular docking can be used to enhance the design of efficacy of CAR-T therapies, particularly regarding predicting interactions between chimeric receptors and antigen expressed on cancer cell surface, which is like a very interesting question.
Yeah. So like it's the part here, it's the part that interests me, like bioinformatician and genomician. So what I can see the future of CAR-T, for example, when you have a patient coming to the lab, to the hospital, we can take the cancer cell, sequence it, and try to identify something unique, really unique to this cancer cell by comparing to a normal cell from the same patient, and take this part that it's unique, and with the docking, with the bioinformatics tools and AI, for example, to create an antigen and specific for this part that it's unique, and use it for production of this CAR-T. And we like this, we will not use CD19, for example, or other receptors known in the body, but we'll use something very specific to these patients. And like this, we will reduce the off-target, and also we will attack specifically this cells. So the AI and the docking, it can help us here to create this specific antigen.
Yeah, so AI, I guess, can help create this supernatural CAR-T, hopefully. Another question in the chat is about, can you explain why there are more CAR-T therapies for hematological cancer rather than solid tumors? So this is another interesting question about the differences between
the T cells are circulator. They will circulate in the blood, and it's very difficult for them to access the solid tumor where it's like a solid block So they will attack the surface of this cancer solid tumor, but it's very difficult for them to access in the different inside these cancer tumors. So there is trials. They are trying like to use it also for the solid, but till now I think the success it's not that good, and we need to find another way how to when we have a solid tumor, not only attack the surface, the outside by this CAR-T, but trying to find a way how to access inside also.
Great. Okay, another question in the chat. The main difficulty to apply CAR-T in solid tumors to penetrate in tumor. This is not a question, actually. This is more a comment. So what is the difference when we use viral vectors or CRISPR-Cas9?
Okay. Viral, you are not controlling where it's your CAR-T will be integrated in your genome. So when you introduce it like this, it will be like a lottery. So it will go and interact with your genome, or maybe in a key gene, and will maybe create off-target also result. But when we use CRISPR, maybe it's better because we will choose exactly where our construct gene, the chimeric construction, will go and interact, and where it will go and like in French we say faufiler, so faufiler inside your genome. Like, okay, so CRISPR will give us more this ability to choose where our construction will be integrated. But the other two are like just a lottery. You are introducing, and sometimes maybe it will fix in key region that you are not, like, you don't want to disturb them.
Okay, so what's the role of the spacer in CAR-T?
The spacer.
Spacer, yeah, I'm not
Okay.
sure I understand the question.
You know that there is a membrane. There is a membrane, so you need to have a spacer that will be in the middle, in between the membrane and the surface. So you have your antigen outside. After there is a space that it's the membrane, and after you have your signaling CD3, for example, outside. So the spacer, it's like to have, it's here. You are talking about this one, not this one, the hinge. Just to give I think, I don't know exactly what is the spacer role, but I think it's to give just enough space to fix with the antigen. Because if there is no spacer, maybe it will be more compact, and you don't have enough space in 3D to fix the antigen. Like this, you have like more 3D and enough space, molecular space to fix the antigen. But I need to check. If maybe I need to check, and after send if the who asked the question can send me an email, and I will check and answer him.
So, Mohamed, this is just more a speculative question about cancer cells that don't present any antigen on their surface. Like in breast cancer, for instance, there is a subtype core tumors, if I'm not wrong. What do you think in terms of this CAR-T development, this CAR-T therapies development, or a parallel therapy for these core tumors?
They don't present any antigen?
I do believe that there is a subtype.
It's not, don't need to be a subtype, but you need to just take these cells and sequence them, or maybe do a proteome of the surface. Like you can lease the cell and take only the membranes, and do a proteomic only for the membranes, like which protein are in the membranes, and to identify your antigen, specific antigen, comparing to a normal cell. You do the experiment in parallel with the tumor cell and normal one, but you take only the surface membranes, and you do a proteomic and to identify your maybe antigen, specific antigen. I don't think that there is a cell without antigen outside. Just you need to find a way how to identify it only. And proteomic can be the solution here also.
Perfect. Another question in the chat is, about can this CAR T be used in all fields, not only in cancer. So I guess viral infections, for instance, and other immune dysregulation or diseases.
We see the price. It's very big and heavy process to produce CAR T. So to use it for infection, I don't think it's like a cost-effective procedure. Like only if it's something maybe very resistant, or maybe they will develop it. But it's like you are using a nuclear bomb to kill a mouse. Like, I don't know. It's not like logic. Okay.
What do you have? Do you have an idea about the use of CAR T therapy in Algeria? If it's not, is it possible to make that happen?
No, there is not yet for the moment, and it's possible to happen, yes, but you need to put a lot of money, because it's very like technique de pointe, or they're in French. It's like very difficult to do. Like there is a few only maybe lab and hospitals in the world that they have this CAR T therapy now. It's not something that open for everyone.
Yeah.
And if you want to make it in Algeria, there is a lot of different steps before to reach this. We need to first to develop the normal some normal strategies, and have the equipment, and to develop it. It's very expensive strategy, like technique, and it will very cost. After, if you want just to use because to extract the T cells, do the antivirus, make it this treatment, it's not like a paracetamol you go to the pharmacy to buy it. It's tailored for each patient. So each patient, we will do the full work. Like we need to extract the T cell and do all creation of the shiminic, introduce it, cultivate it in the lab, introduce it back to the body, give the medicine for anticide. It's a big and process, and it's not a medicine that you can go and buy. You will have only you can buy, but you still have to introduce your antigen or something. Like this medicine that the 6, they are using CD19, that it's like common for everything. We can use it you can buy it from outside and use it in Algeria, but you need to have hospitals that they know how to deal with the side effects of this therapy. So if you give it to someone in the clinic in Algeria, you need to be ready to deal with all the side effects or the follow-up also later. So you cannot just give it and let the patient go home. So you need to have all the infrastructure with it.
Yeah, I guess maybe there is room for private investment and pharma companies in Algeria to do that, not research labs.
Maybe, yes, maybe if it's private, yes.
Yeah. So actually there is a question from Lahmadi of CRBT. It was about the issue between looking into solid tumors compared to other cell types or tumor types. And Lahmadi, if you want to ask your question in person, please go ahead. If not, the question says the main difficulty to apply CAR T in solid tumors to penetrate immune cells to tumor, TME more complicated. I guess you answered already the question.
Yes, I already, yes.
Yeah. Okay, so personalized medicine seems to be priority in Algeria. Perfect phase, thank you. Maybe one last question from the chat. In steps of T cell expansion in vitro, the cell T become more proliferative. How to control T cell in patient to kind of, control this proliferation, I guess, if my understanding
You
is...
think we need to control it? I think it's a reverse, because it's not very proliferative. So we need it's why in these generations we add we add more these domains to make her proliferate. We want her to proliferate more. So the problem of CAR T, it's that the number is reduced, not increasing. If I understand the question. No?
Yeah, I do believe that we have issues with expansion and proliferation, not the opposite. Okay.
Yes, the opposite. Yes.
Yeah. So there is another question from Talia. Does the success of CAR T therapy related to the stage of the cancer? How if yes? And does the combination of CAR T with PD-1 inhibitor will improve the success of the therapy?
Yes, it's what I showed. I think I showed it in, where is it? Yes, here. So in general, now they are combining these two techniques, like anti-PD-1 and anti-CTL4 with CAR T. So to increase more the efficacy of the CAR T. Because these two will make the cancer cell more visible. Because in general, even if CAR T cell have, if the cancer presenting this PDL1 ligand, what happened that it will fix, even if it's recognized that it's tumor, this one will like block all any activity against it. It's like the common frein. Donc, it's a risk with CAR T. So if we introduce this therapy also, so we will block this break and allow the CAR T to do her job more effectively. So there is some patients, they receive, like, I think, combination between the two.
Perfect. Okay.
And I showed in one of the slides that in general, we use multiple, I think, where is it? It's never only one, but we use different, where is it? I think I lost it. Right. Yes, here. So you can see that we use different, like, therapy with CAR T, chemo, and also the combination between them, and also with this anti-PL1, and so to make it more effective. We never give CAR T alone, like.
Another question in the chat, how about fasting to produce a good T lymphocytes?
I didn't listen.
How about fasting to produce a good T lymphocytes? Is
fasting to produce what?
Good T lymphocytes. I think the question is about fasting and its effect on making the immune system better, right? The Khalfa Murad, yes, go ahead.
Yes.
Yeah, there is an echo. Okay.
Yes, I think that for autophagy, I talk about autophagy. Fasting, as you know, we can produce a good T lymphocyte. What do you think about when we take blood from patients? There is a difference between lymphocyte, T lymphocyte produced for a patient who do fasting or no.
Oh, okay. I don't know. I don't have the answer, but it's good, the question. Like, if really fasting generate a better lymphocyte or make it better, it's good. So to ask the patient before to extract the T cells, to let him fast for 2 days, 3 days. But I don't know, for a patient who is sick, if we can tell him to fast, especially cancer with like a patient. But yes, maybe, I don't know. I don't have the answer, but if you think that it will produce better tea, but better tea, if you can explain to me better tea, how? What is better in this tea?
I think it is a good project. Huh? Okay. It is a good project to do it. Huh?
But what is, if you can answer me just this question, what is, when you say it's better tea, what is the, to qualify them better, what they have more than the normal tea?
I think it's the number, maybe more.
Number, but
or the
not the quality. Maybe.
Yes. Yeah.
Like more viable and, you know.
I don't know. Maybe I will check. This is good question. Yes.
Okay, perfect. Think we are on the top of the hour, and I don't think there is any question left in the chat. If you have a burning question, please go ahead and ask in person. If not, I think we are ready to wrap up the call. So, Dr. Belhocine, thank you so much for your time today and for this very
Thank you.
interesting talk. And the questions were very interesting also. So, thank you all for joining today, and I hope to see you next week.
Thank you. Bye.
Take care. Bye.